EM board bombs.
Welcome back to EM Board Bombs. I'm joined here by Dr. Briggs, my co-host. We're going to be rocking out today. We have a little special treat here as well. But before we get into that special treat, hey, who are we? EM Board Bombs. If you don't know us by now, I don't know. Are you like living underneath a rock or something? I think people know what we do, Briggs. We're the blue collar EM podcast. We drop high yield board review. That's what we do. And we do it in a simple way. We're not really getting into pathophys and a bunch of other stuff.
Usually it's one sentence.
Yeah, usually it's just one sentence. That's it. But hey, that's what we do.
Hashtag listen to my recent episode on temporal arteritis when I said the pathophys, it's about one sentence. It's a systemic vasculitis.
There you go. Done. That's kind of like the summary that encapsulates our whole podcast. Hey, shout out to EM News. Right, Briggs?
Right. Yeah. Emergency Medicine News as our sole sponsor. We're very proud to have them as our only sponsor of this podcast. Yeah. You can check out their website, emnews.com, of course. They offer, free editorials, free journals for anyone who's a practicing emergency physician. So all you need to do is email them and set up a subscription. That's how awesome it is. So you get great content.
And to those who have reached out to us to also, sponsor, again, it's a no. So we're good. The special treat that we have here right now is what?
Mm-hmm. We have a nice sneak peek into what our Rapid Bombs podcast is, where we essentially give you coaching, spaced repetition, all those buzzwords. We tell you what you need to know for the boards. And this episode, we're going through some high yield rapid board blitz. We've done it before on the Rapid Bombs podcast several times where we've gone over, I think one episode we did bites, stings, and ouchies. Just those classic, environmental exposures you need to know. Yeah. We did another podcast on like antidotes that you had to know for the boards, for tox. Yeah. And we've done other Pearl episodes. This is just one sneak peek into what we're doing with those. We like to get together and show you kind of what you're missing if you're not a premium subscriber.
Yeah, and the cool thing with Pearls is we just drop them hot, and that's it. A lot of people,
hot pearls.
I know, just hot pearls. That's it. And a lot of people, they like the question and answer, but this mixes it up, and it's a format that we're using more on EM Rapid Bombs as well. That people tend to gravitate towards, and the feedback has been great. So we drop a ton of pearls, these pearl-like episodes, but this is just going to be a short preview, just so people have an idea, and our main channel will get some benefit as well.
All right, we got these pearls to go through. Some of them are actually combined, so it's actually 10, but it's kind of like, buy one, get one free for a few of these. If you've ever done that at the grocery store, very nice, rewarding, day when you go there. It's buy one, get one at Publix. Anyway, we're not sponsored by Publix, by the way.
We love Publix.
Yeah. All right, so pearl number 1, what are the classic EKG findings in pericarditis? Not always there, but for the boards, what are they?
Diffuse PR depressions and ST elevation. Often the EKG is also going to show tachycardia. Remember that one. And also remember that pericarditis is often associated with a pericardial effusion on bedside ultrasound. So if you have a classic presentation or even a presentation that's concerning for pericarditis, do that bedside ultrasound. If you see that pericardial effusion, it's going to lead you more towards that diagnosis. Hey, Pearl 2, Dr. Briggs, what syndrome is associated with biphasic T waves in V2 and V3?
The most common one you have to worry about, there's actually a few, but by far the most board relevant is Wellens syndrome.
Boom.
And the follow-up to this is an early sign you have to watch out for is this is apparently an early sign for a proximal LAD occlusion. Essentially, they're going to infarct within 24 hours.
Oh, yeah.
So you don't stress test these patients, and you don't have to technically call a STEMI, but they absolutely need a cath within the first 12 to 24 hours.
Yeah, like this is not that patient that you're doing a heart score on and figuring out risk. No, this is one that gets admitted to cardiology.
Right. Hey, so pearl number 3, we're going to continue down the EKG trend here.
Right.
EKG findings associated with HOCM. So classic. We've had so many rapid bombs on this. I love this condition.
I know.
Love asking residents about this.
I know. Deep, narrow, and then just remember this phrase, dagger-like Q waves in lateral leads, right? So 1 AVL, V5 through V6, plus or minus inferior, so 2-3 AVF leads. But deep dagger-like Q waves, especially in lateral leads.
That was one of the call signs, by the way, in Top Gun Maverick.
There you go.
Dagger.
1 AVL, V5, and V6. So for hypertrophic cardiomyopathy, the likely patient presentation is going to be one who presents with syncope. It's going to be a relatively young patient. Right. They're not going to
syncope while doing something.
Yeah, syncope, exactly. Exertional syncope. You know, that classic playing a soccer game or something like that. And they might describe this family history of syncope as well. For apical hokum, you'll see very deep T-wave inversions in the precordial leads. Again, that's for apical hokum. But for this one, though, just remember the dagger-like Q waves in the lateral leads. So, Pearl 4, we're going to keep going the cardiology route. Chest pain with EKG that shows ST depression in V1 through V3. What should you be worried about, Dr. Briggs?
I learned this intern year. Shout out Dr. Masneri, Associate Program Director at Wake Forest. Consider posterior MI in this case. Yep. It's one of those cases where you're looking for the ST segment elevation. You don't see it. It's because it's not there. It's on the back.
Yep. On the back.
You turn the EKG over. It's it's double-sided. Anyway, the question here, it might give you options on the test of what's the next best step, which of course would be getting a posterior EKG. That's a little nuanced. So instead, they're going to ask about, hey, what's going on with this patient? Or, technically it's a myocardial infarction. You just don't see the elevation. Right. And essentially the key leads you're going to get here are 7, 8, and 9. It's literally a mirror object of where the front 4, 5, and 6 go. You're just putting those on the back, lining up with 4, 5, and 6. They're posterior to the patient. Just Google an image of this, and honestly, it's just going to make much more sense to me trying to explain it. And the diagnostic here is actually quite easy. The diagnostic EKG for posterior MI that requires activation of the cath lab is only 0.5 millimeter ST segment elevation. That is very low compared to what it normally should be for the anterior. And it's going to be in 2 or more contiguous leads. Very easy to meet criteria for that if you see. Cool. Hey, so what syndrome...
Pearl 5, come on now. You got to let
Pearl
people
5.
know.
Pearl 5, sorry, I was so excited to tell you this. It's like Jeopardy. What syndrome do you consider in a patient with pleuritic chest pain 4 weeks after an MI? This is like med student era, step 1, USMLE.
I know.
Yeah. Besides a PE, what do you...
I know, right? Dressler syndrome, right? So it's an autoimmune pericarditis, usually 2 to 6 weeks post-MI. Patients present febrile with EKG findings consistent with pericarditis. The treatment here is going to be NSAIDs. The way this question, I know, right? And the way they're going to ask this question, it's going to be, the recognizing that this is an autoimmune phenomenon and understanding that NSAIDs are first-line treatment. Obviously, when they ask the question, they're going to make it clear the patient had a recent MI. You should be able to knock this one out of the park because there's only like a limited number of ways you can ask this question. Hey, let's do some shorts. Let's end this with 2 shorts. What do you think?
Yeah, let's do it.
Okay, so we're gonna wrap up 2 pearls in one here. All right, it's a 2 for 1. 2 for 1.
2 for 1. Buy one, get one free.
So yeah, pearl 6 and 7. Yeah. Okay, do I have to look at the camera again? Is that how you do shorts?
Yeah, and do the little finger thing we talked about last time. Hopefully you've learned your lesson.
Oh my gosh, I still don't know.
Hopefully our Alexander, our PR expert, will put sparkles and a new filter on your face too. Make her eyelashes longer. I
really hope she doesn't do all that. Okay.
Oh, she's going to do it. She's laughing.
Let's do it short. Let's just do the short. Okay. So just, I always get nervous with these.
If you're on YouTube right now, you're going to get a kick out of this. For those of you listening on audio, check out our YouTube channel.
They're calling me that person who doesn't know how to use technology. There's a phrase for that. All right.
Yes. So, I wonder what it is, which is ironic considering what you used to do when you were younger.
I know. And the trailblazing I did, right? Oh,
yeah.
So
it's over.
Pearl, I know. I hit my peak. Pearl 6 and 7. What is the characteristic EKG findings associated with cardiac tamponade? Electrical alternans. This is the beat-to-beat alternation in the height and the amplitude of the QRS complexes. Make sure you look at a few of these EKGs because it's ridiculously easy to test on for the EKG. I feel like they're going to include this on every single ITE and every single board, right? I mean, it's just so easy to get.
It's a little subtle, actually, if you're not paying attention.
Right. I have to continue I have to continue the short.
Sorry.
How do cardiac tamponade patients present? Remember this, demographic, right? Patients with ESRD, oncology patients, recent cardiac surgery. The clinical presentation is one of shortness of breath, chest pain that is pleuritic. And lastly, we're going to review that triad. What's that triad, Briggs?
Beck's triad, which
there
never
you go.
happens.
Hypotension, distended neck veins, muffled heart sounds. Remember, Beck's triad is the classical presentation, but rarely does it present with all of these. Done.
The only thing you have really to help you is the ultrasound.
There you go. There you go.
Nothing else will help you.
Nothing else.
Nothing else.
All right, are you going to do the short now?
Pearl 8. No, it's not a short. It's just a simple pearl.
Oh, we're going
Simple
back
pearl.
to normal. Let's go
Normal
back to
pearls.
Normal. All right.
What is the only contraindication to aspirin for a patient with true ACS? Not acute chest syndrome, but acute coronary syndrome. Not acute compartment syndrome.
Anaphylaxis. It's really just anaphylaxis, right?
Yeah.
You know,
That's it.
we did a rapid bomb on this in the past that explained the importance of aspirin and how the number needed to treat is like so ridiculous when it comes to ACS. It's like on par with like stenting these patients and stuff. It's just crazy. So even if you've given the aspirin rectal because the patient is intubated, you just have to give the patient aspirin for ACS. It's literally the most important medicine you give for ACS in the ED setting. Way more important than like heparin. So please, aspirin is the most important thing.
Even if they're intubated,
Yeah.
you could still give it an anaphylaxis. Doesn't matter.
I know, right? They need that.
Sorry, side comment.
Side comment. They really
Hey,
do.
time for a short.
Okay, you're going to do the short.
Leave me on. Leave me on.
All right. So,
I'm so
all right,
excited.
Dr. Briggs.
I'm so
all right,
excited.
Dr. Briggs. It's time for a short. Pearl 9 and 10, a 2-for-1.
2 for 1. What agents do you use to treat chest pain if someone did cocaine? What do you think?
Benzos.
You have to. Oh no, you're answering it. Oh
No,
my gosh,
you do it.
You
You
ruined
do
it. I was letting the audience. I was
Okay,
looking
start
at
again,
them in
start
the
again,
eye,
start
and
again,
staring
start
into their soul.
Start
No,
again,
we're not
start
redoing this. We're not redoing this. Benzos for symptomatic relief, and then for hypertension, tachycardia from the sympathetic effect of cocaine, you're considering calcium channel blockers and nitroprusside. But that shouldn't happen really ever. Now, this is a really unfortunate part. It pains me to say this because in real life, it's just not true.
Sure.
But on the test, you don't want to give beta blockers due to these concerns for this unopposed alpha thing that happens with cocaine
Theoretical,
use.
only in
It's all theoretical.
lab
It's
mice.
never been studied. They were
Just
done in animals, not
in
humans.
animals, that's it.
I know. Never studied in humans. It'll never will be studied in humans. But the point is, in real life, no one cares. In the test, just don't do it. Calcium channel blockers, benzos. Really, benzos are your number one. On the test, if they give you all these drug options, and it's like if the patient's tachycardic, cocaine use, and or hypertensive, and or chest pain, benzos are the answer. The backup option is, hey, if you give it the benzo already, you can give a calcium channel blocker.
Hey, this next one though that you're wrapping
I'm
into your reel or your short or whatever is my favorite because you and I had a patient like this. Remember in your residency when you were a third year. I know.
And the toxicologist made fun of us.
I still remember what bed that patient was in too. But anyways, for a patient with wide complex tachycardia secondary to cocaine use, what is your first line?
Sodium bicarb.
Please. Now, how much more?
Sodium bicarb.
There you
Sodium
go.
bicarb.
There
Sodium
you go.
bicarb.
There you go.
Sodium bicarb.
Yep.
And of course, benzos for agitation, but sodium bicarb.
Sodium bicarb.
You were giving them tons of sodium bicarb. You're giving them as much sodium bicarb as possible until it, apparently one of the toxicologists we both know said until it starts to precipitate out into the bloodstream, you were giving sodium bicarb because you're trying to close the QRS. Remember, cocaine is a sodium channel blocker. Sodium bicarb, you're giving that. It's just like a TCA thing, the cocaine, right?
Yep.
And so you're giving sodium bicarb to close that QRS, stop the seizures, stop the wide complex tachycardia.
Yeah,
you give this
really first line. There you go.
First line, you're giving this way above any other antiarrhythmic. Antiarrhythmics can kill patients. They will kill the patient. If you give amiodarone to a cocaine overdose with wide complex tachycardia, they will die. Amal Mattu talks about this too. Shout out to Amal Mattu.
Shout out Amal.
That's all I got.
Love you, man.
Love him.
A former host of EM Board Bombs as well. Great guy. Hey, so I think that's it. We're done. People got a preview of what our Pearl rapid bombs are like. I hope they like it. If you like it, go to emboardbombs.com. You can find our Rapid Bombs podcast there. Subscribe with 2 clicks. It's very easy to do. It's going to prepare you for IT boards and also life. We have, people still listening from more than 2 years now and, listening to every episode. It's really cool to see that. So
sure is.
Prepare you for life, boards, Pearl, just everything. Cool. Hey, Briggs, we're going to be out for a while now until the new year.
Coming up.
So looking forward to seeing everyone for the new year. A lot of fun things coming down the pipeline for EM Board Bombs for next year.
Yeah, you thought you enjoyed our new website. Just wait until 2024 when we unveil even more exciting things.
I know. It's going to be fun. This was the year of the new website and really growing out EM Rapid Bombs. And then
oh man, get ready.
We got a lot of new content, new types of things that are either going to work really well or just completely flop.
And we'll still enjoy them nonetheless.
We're going to enjoy the ride like we always do, Briggs. We're going to enjoy the ride, my friend. Okay. Hey, hope you have a good New Year, man. Hope you have a good Christmas and spend some good time with family. All right.
Much appreciated.
Take care, man.
All right. I'll talk to you later. See you.